Botox is not just for the face. We actually do it into the voice box as well in laryngeal dystonias to help people speak normally again. Now let me explain it to you how we do it. The first most important step is reconstitution. For that, we use a 100-unit Botox vial and reconstitute it using preservative-free normal saline. Now, depending on the concentration required, we can either dilute it with 4 ml or 6 ml of normal saline. A 4 ml dilution gives a higher concentration, while 6 ml gives a more diluted preparation, which allows us to make more finer adjustment of dosage during laryngeal injection. In adductor spasmodic dysphonia, Botox is usually injected into the thyroarytenoid muscle in doses ranging from 0.5 to 2.5 units each side. A practical starting point would be to use a mid-range dose like 1.25 units, and in future sessions, which has to be repeated usually in 3 to 4 months, the dose can be titrated depending on the patient's symptomatic relief or side effects such as breathiness. In abductor spasmodic dysphonia, we require higher dosage ranging from 3.75 to 7.5 units. To avoid airway risk, it should be injected unilaterally first in the posterior cricoarytenoid muscle, and the other posterior cricoarytenoid muscle can be targeted approximately 2 weeks later. Now, how do we actually perform the injection? We can either do it using the electromyography machine, that is through EMG guided percutaneous approach, or using fiber optic laryngoscopy. For EMG guided approach, we need a monopolar concentric 25 or 27 gauge needle, which is an injection needle connected to the EMG machine. Next, we position the patient either in supine or sitting position with neck extended. We then identify the important landmarks and mark them, that is the thyroid notch, the inferior border of thyroid cartilage, cricothyroid membrane, and the superior border of cricoid cartilage, as well as the midline. For thyroarytenoid muscle, needle is inserted through the cricothyroid membrane near the midline until the resistance is felt, and then the needle is redirected 30 degrees laterally and 15 degrees superiorly to enter the thyroarytenoid muscle. As soon as we enter the thyroarytenoid muscle, you hear the EMG activity, which can be heard as C-wave sound. You can further confirm the entry to the muscle by asking the patient to phonate E and see the wave. And then the appropriate dosage of Botox is injected. The same procedure is repeated on the other side. For posterior cricoarytenoid injection, the one commonly used technique is to gently rotate the larynx to the opposite side and then insert the needle through the lateral aspect, or you can also insert the needle into the airway lumen through the cricothyroid membrane and then pass it posteriorly to enter the PCA muscle. The entry into the muscle can be confirmed by asking the patient to sniff. After the procedure, the patient is usually observed briefly and can go home the same day. Voice improvement does take time. Usually it starts within few days, and maximum effect is seen up to 1 to 2 weeks of injection. For more such videos simplifying laryngology and voice disorders, subscribe to the channel.